Welcome to today's event. This is Practice Informed Conversations, Real World Perspectives on Rural Mental Health with Dr. Lori Raney. And really quickly, just a brief disclaimer that all of our work and the work of the larger CMIS network is all supported by a grant from the Substance Abuse and Mental Health Services Administration. And also, please note that we will be recording all of today's session. So one more time, please check the chat. Stephanie has dropped the link for today's pre-event survey in there for you to go ahead and fill out while I finish introducing our speaker and then get it handed over to her. All right. I am very excited to introduce today Dr. Lori Raney. Dr. Raney is a faculty psychiatrist at Mountain Area Health Center in Asheville, North Carolina. She has worked in diverse rural locations, including federally qualified health centers, rural health centers, tribal clinics, and school-based health centers. She served for 15 years as the medical director for a community mental health center in Colorado. And while there, she participated in the design of a fully integrated healthcare facility that combines both primary care and traditional behavioral health. She has worked for over 20 years with the Indian Health Service for multiple tribal communities in the Southwest. In her current work, she helps provide care to individuals in rural Appalachia. She was raised in Bladen County, a rural community in eastern North Carolina. She finds this work challenging, rewarding, and very personal. And without any further ado, I'm going to stop sharing and turn it over to you.
Here is C. Okay, there we go with our swapping of the shared screen. Good morning, everybody, or actually, I guess it's afternoon at this point. Thank you for that lovely introduction. I really appreciate it. As we mentioned, our conversation for today is around practicing behavioral health in rural locations. I'd be very curious where our attendees are practicing. If you're in a rural area, urban area, metropolitan area, what does that look like for you? What's that location? Because you may absolutely have things to add and join in the chat box to some of the things that I'm going to talk about. And I really love to tailor this to what's going on in your world so that we get to some things that would be helpful. We're also going to spend some time in a discussion session at the end. This is not going to be an hour of PowerPoint. It's meant to be a conversation, as mentioned earlier. So I'm just going to show a few slides. I'm going to talk about what I've done, my experience, some of the things that I think have been positives and challenging in my career, and then open it up to everyone because I think we all have the ability to learn from each other. So what we're going to try to do is talk about some barriers to rural mental health practice. What are the facilitators in terms of what are those positive things that we can do around making this more successful? And then what are some of the solutions to providing effective care? A little about me. I am from a rural North Carolina tobacco farming community. The roads were lined with tobacco fields where I was growing up and tobacco drying barns. My first job out of training was with the Indian Health Service. For those of you who have been to Monument Valley, you probably recognize the mittens sitting out there in Monument Valley. If you've never been there, I think it's a great place to go. This is actually frontier. There's rural and frontier. I think frontier is less than 7 people per square mile, and I think rural is less than 15 people per square mile. So this was rural, and it was cross-cultural for me. I worked with the Dene or Navajo population on their reservation lands. And then my job after this, I love this place so much, I went up just to the edge of Colorado and close to Durango and worked in a rural area of Colorado as the medical director and spent 15 years there just living out west and living a very rural life, kind of in the middle of nowhere. It's one of the few places you can get on 35 acres and have a house and not see your neighbors. So I came from a small town. I've worked in these rural areas, And it sort of fits for me and my personality. I was actually quite used to doing it. And then now I've moved out to rural Appalachia and I'm in Asheville, but we serve all of Western North Carolina because there are few, if any, behavioral health and psychiatric folks in those areas. So now I get that experience moving closer back to home. My mom just turned 89, so getting back into North Carolina has been really good for me as a practicing psychiatrist, but also to be a little closer to my family who've been rural forever. They're still in Bladen County. So let's talk about, kind of what my experience has been in rural practice. And again, I'm really curious to hear what yours has been. But the communities are much more tight knit. The families ties are much stronger. When I have worked in some towns like in Durango, and even for patients who come from the town here in Asheville, there's not as much connection to family. I don't have these other people I can talk to and collaborate with who come in even to the appointment with the patient concerned, ready to support or not. Sometimes you can actually see the problems when the family does come in. But it's been really nice to work in these tight-knit communities. When things happen to me, when things happen to folks in the community, there's a real rallying around that person in that situation. Be it we had a homeless guy who froze to death in the park. All of a sudden, the community rallied, and within a year, close to actually 6 months to a year, we had set up a homeless shelter because that in a tiny community, a homeless guy dying in a tiny community really just touched the heartstrings of the community. And we set something up where we only had about 10 or 15 folks that were homeless, most of them coming over from the reservation who the reservation was dry and they would come over to get alcohol and had some substance use problems. So that's what I mean about just tight knit people belonging to the churches and the community and the groups was I found to be really fascinating. I think in the city, in metropolitan urban areas, you can sometimes be lonelier than you are out in the middle of a rural community. That was just a total surprise to me, both in my practice and just sort of family wise. When you're in a small clinic, there's a team environment. Everyone knows your birthday. They know what's going on with you, good or bad. You're helping each other out. I just found that I knew everybody. Everyone knew me. I knew the janitor. We'd have a chat every time he came in to empty my trash can. It was just really cool to work in an environment like that. I had a broad scope of practice. I'm an adult psychiatrist. I was able to do child psychiatry. I sort of had to. The primary care providers and other folks would look at me and say, "Well, you know more than I do." It's really hard to say you don't know you're not a child psychiatrist because, well, heck, you can help me more than having absolutely nothing out here. My primary care doctors saw the same thing. They were doing stuff in the emergency room that they would never do if they lived in an urban area. So you really got that broad scope of really doing stuff that I learned about it in residency. I had no idea I was going to actually get to practice it. There are a lot of federally qualified health centers out in rural areas. They have nice extra funding, that nice Medicaid bump. Almost all of them have some behavioral health in them. My organization here in Asheville, we are an FQHC or a community health center. I'm wondering if some of you might actually work in that area. And then I've also found in all the places I've worked, there's just really some natural beauty, hiking and woods and places you're just not going to see much in an urban or metropolitan area. You're going to have to travel to go see that. This is actually the view out of my kitchen window in Southwest Colorado. We call it alpenglow at sunset. So it's just in so many places really beautiful to be out there, actually away from the cities and the crowds. I have my out in Colorado, I lived in a town where we had 0 stoplights, and we still have no stoplights. I'm really hoping they don't mess it up by putting a stoplight in one day. The challenges, and I know you guys are familiar with this, is really recruiting and retaining well-trained staff. You have sometimes a limited applicant pool. There are some things the federal government and others are trying to do in terms of loan repayment, those sorts of things to get people out to the communities. Sometimes there are lower salaries associated with that. you can sometimes experience professional isolation. And for me, it was just being involved with my professional organization and going to meetings, and actually, especially out on the Indian reservation, on the Navajo reservation, trying to actually get my psychiatrist colleagues together from diverse corners. The reservation is the size of West Virginia, and we'd all meet in the middle of the place at a restaurant, so that we could continue and not feel so professionally isolated. You can make this stuff happen. You just have to work at it a bit. Reimbursement for services can be sometimes limited or lower, although FQHCs are certainly the exception with the Medicaid bump. A lot of folks out in rural communities have Medicaid. And then it's sometimes hard to get advanced training, and people need the advanced training because they need to be able to serve a diverse population. You can't just go in with, supportive psychotherapy, interpersonal psychotherapy. That's all I know. It's like, well, I need you to know DBT, and maybe a few of you to know EMDR, and maybe PCIT for some of our PEDS patients, trauma-focused CBT. And so really getting that training out there is important, because sometimes you have limited staff. And so those staff need to have just like I had a broad range of practice as a doctor, we needed the therapist to have a broad range of practice too. We did a lot of training the trainer stuff, because it's really hard to send everybody off. So we would do training the trainer type programs in the organization. So these are just some of those challenges, and I'm guessing there's probably others, and I'm guessing that many of you have some examples. And again, feel free to drop things in the chat box. When I first went out there, my office was in a tiny house, and there was a branch over the office that I figured one day during a storm was actually going to fall and come through the roof of that house and my office. So sometimes behavioral health is also in these smaller communities. I call it outback. Outback in the trailer was what it was on the Navajo reservation. There was a hole in the floor, and then this little house in Cortez, Colorado, where I figured it might actually fall in one day. We eventually built a new clinic, but there's just some of the things that you sometimes experience in rural areas where you may not have the funding that you wish you had in other areas. So what are the solutions that I have found? I'm curious what solutions you guys have found for some of these barriers that I have personally experienced out in these rural areas. What's kind of emerging in the field right now in terms of us thinking about what could potentially happen to address the need? Because we've been talking, I mean, we couldn't hire, it was really hard to get a social worker out on the Navajo reservation. So these problems go back 30 years of my career. Some of the things you're experiencing today, they were the same things we were experiencing 30 years ago. So this stuff isn't new, but maybe the solutions are shifting, and maybe you guys also have had some particular solutions that have or have not worked for you. And I'm just looking, we got some folks from Marion and Carroll County and Roanoke. Okay, good. Tennessee. It's really good to kind of see where you guys are coming from. So you guys, many of you know what I'm talking about in terms of being out in these rural communities. Marion's just down the road from me, and I don't know if the person from Marion has done any work with Mayhec or our clinic up here, but certainly Marion is, they've had hardships from industry leaving town and isolation, but I hear there's a couple good restaurants opening down there. So we'll see what happens with Marion over time. So what are the solutions? What have I sort of found that might help with some of these issues that we've talked about? So I've always said, make the job interesting. So if you have social workers, psychiatrists, primary care, whatever it is, try to get people out and about in different locations if they want to do that. Some people like, if you have a therapist and everything, and it's kind of the traditional 1 hour psychotherapy appointments, 6 to 7 appointments a day, patient after patient. Remember, 2 to 3 of them no show, sometimes more. Some people like that. It's kind of setting up almost like a private practice model. But what I enjoyed was actually going and doing different things. And it actually helped me keep my psychiatrist a little bit longer because I made it interesting. They would go to the hospital, they would go to schools, they would go to primary care clinics. I went to the jail for 15 years. I'm not a forensic psychiatrist, but I went over and worked in the jail. And so I was hopping around and doing different things, involved in different kinds. It was all patient care, but I made it interesting for myself and for my staff. The other thing, of course, is loan repayment, really checking out if you're in a medically underserved area. Many of you probably your staff would qualify for loan repayment. Can you add relocation expenses? The Indian Health Service will move you. They're federal, but they'll actually get you where you need to go. Are you guys doing that? Do you have any signing bonuses? What are those things that look like on the front end of getting people hired and brought in? We used to always do a potluck. So whoever came in to interview, we got them out there. We showed them around. We showed them what's beautiful, what works, and we had them meet some people, meet some social workers, meet some other doctors, meet some folks that they would be working with, because you can ask, well, how do you survive out here? What's this been like for you? And really hear from other people. That's how I ended up way out there where Monument Valley is. It's like you drive out there and you go, wow, there's no way. I don't think I can do this. And you get out there and you talk to everybody and you go, well, yeah, I can. The other thing is to partner with your local areas of higher education. We have AB Tech here. There are community colleges. I think Western Carolina's out here. We also have UNCA and other places, but partner with them. What are those early pathways? So what we have done is get students. You have to be willing. I mean, you guys who have students, it's a little bit extra work, but I have had a lot of luck, in particular hiring psychiatric nurse practitioners. I've had a lot of luck by being willing to precept with the local nurse practitioner psychiatry program. So they were up in Denver. I was down in Cortez, Durango area, and I would take their students for 6 months. And I was able, out of 4 students, to hire half of them. So I was able to hire 2. And it's a lot of work. They have to come in, present their patients. You got to talk, you got to teach. But it ended up with me being able to recruit and retain. One of the nurse practitioners is actually still there. I keep up with her. She fell in love with rural Colorado and hasn't moved until she retires. So just finding ways to get students interested. Sometimes high school students would come in, sometimes college kids, people with psychology, social work degrees. And we also were able to provide a bit of a pathway. So a lot of folks came into our community mental health center as case managers, and they would look around and see our social workers and see how much more money they made and see how kind of cool their job was. And we were able to get them to go to social work school. And then many of them then came back to be our social workers. And the University of Denver set up kind of a branch of their social work school a little closer to us, so there wouldn't be as much travel. We didn't have online training back then. That wasn't part of the deal. Now, you had to go to classes in person, but you did have to do your clinical hours. So really offering those precepting opportunities, clinical rotations. Hours towards licensure is a big one. A lot of folks that are unlicensed come into these rural communities. They're exceptions or they're simply allowed, and they need 2,000, 3,000 hours of supervision. And it's really cool for us to be able to provide that. Now, we had a stipulation. You had to stay for 2 years after you got your license. And if you didn't, you had to pay back the supervision. So that really helped us and from a staffing standpoint. And if people left, they left, but we had them for 3 or 4 years, which was great. I think we only had one person ever leave before the 2-year commitment, and they simply paid back the supervision hours. And so the other thing is to really try everything you can to invest in these continuing education funds. I talked before about how we need a lot more generalists. You can't have one person in the organization that knows EMDR, or one person who knows DBT, or one person who knows specific treatment for OCD, for example. You really want to spread that around. And we sent 2 people to DBT, train the trainer class. And then the best way to teach DBT folks is not to send people out for training, but to have them then sit in with the people that are experienced and learn DBT. So after we trained the 2 folks, the rest of people, they learned along the way. You don't have to be certified in DBT to do DBT. You just need to know how to do it. So we did it with folks actually learning from experienced person in the room and beginning to take on more and more. Their 21 DBT skills, taking on more and more of actually teaching those skills along with the trained person. And we do that here. And it's really a cool way to learn. And I think it's a whole lot better than sitting in a classroom. And getting DBT certified, I don't know what that does for you unless you want to go on and be a trainer. But in an organization, it's really thinking about we need the skills, not necessarily a certification. What's that training and how do we get it? And how do we use things like train the trainer? I don't know if any of you have used Project Echo. Their whole goal is to get training out to rural areas. They started with hepatitis C, and they did a huge expansion during the early opioid epidemic. There was a lot of teaching how to work with people with opioid use disorder early on. They're still doing it. They're out of New Mexico. They were one gastroenterologist trying to treat hepatitis C all across a very remote state. That was just south of me in Colorado. So Project Echo is a way to also do some training and group training so that you actually learn from each other through case-based learning. What are those patient care opportunities that come up with continuing education, giving people CME time away. I would go off to APA meetings and do their disaster training and then come back and was able to deal much more competently when things happen in my community. Imagine if folks had a lot of disaster training before Hurricane Helene. For those of you from North Carolina, especially Western North Carolina, know what a disaster that was for us and how to respond to a disaster in your community, because you now become the go-to person. It's not like you're in New York and there's 20 universities with psychiatry programs or whatever that you can go get a spokesperson and some help. You're the only one. And so what's that specialized training that can happen at your organization that then folks bring back and really spread around? And then the other is those relationships in the community to kind of help you with recruitment and retention. What does that look like in terms of getting people involved in, if it's the Humane Society out where we were, there was a spay and neuter van that came around because we had so many animals that were just kind of wandering around and hungry and shabby looking. And we would try to make sure we got animals spayed and neutered, so we didn't have a lot of that. You could go volunteer with that. There's all kinds of ways to help support people getting involved and encouraging that, getting involved in the community. We don't want people sitting home and scrolling Facebook, or doom scrolling Facebook, I call it, instead of really getting out into the communities, because those folks are probably not going to get connected and want to stay in the long run. So what does that look like in terms of helping your staff connect with the community? So these are just kind of some of the solutions and stuff that I have thought about going through this process. The other thing is when I first started my practice, I was with the Indian Health Service, and mental health, dental, optometry, and primary care, we were all together. And that's just how the Indian Health Service rolls. That's how FQHCs do it. For those of you in FQHCs, you have a pharmacy. With any luck, you have dental, optometry. Those are added on. Almost everybody now has behavioral health, and then primary care. So everyone's in the same building. And how do we connect, and how do we help each other with patient care? How do we go upstream to get folks with less complex issues so that we can actually save our behavioral health staff for what they're most skilled with? Integrated care is a big deal in Indian Health Service, the Veterans Administration, in FQHCs. And there's a real taking advantage of having those kinds of staff members working together instead of everyone getting referred out to mental health. Because then you got a whole bunch of overwhelmed mental health staff, a long waiting list, patients frustrated out there on the waiting list, or just even when you call them up or schedule them, they no show because they've been on the waiting list so long they forgot what got them on there to start with. So how do we look at going upstream and looking at solutions with primary care? And that is, I think, most of my career has actually been devoted to how do I help primary care take care of folks with less complex problems. So send me schizophrenia, send me the worst patients with the worst bipolar disorder, send me those folks. Don't send me the easy stuff. Let me help you do the easy stuff. And nationwide, there are now opportunities with the collaborative care codes. It's a big deal right now in North Carolina and North Carolina Medicaid to pay for many of the integrated care codes, get them covered so that you're not going in the red trying to do this. So we're seeing a lot of contracting going on between behavioral health organizations and primary care to get some social workers, behavioral health people over and in those primary care and other settings. You can certainly use telehealth both for therapy and psychiatry services. Many patients, when they come see you, they're already going to talkiatry or there's a whole teletherapy organization. They're looking it up. Most of them don't take their insurance, so they're paying out of pocket, and they'll eventually come to us because they just can't afford it. But you can certainly take advantage of telehealth. It's a little issue in some communities. Sometimes these small communities or tribal, there might be some resistance to telehealth, but how can we think about that and potentially overcome that with our patients so that they can get a good evidence-based effective treatment? There are psychiatry access lines. Some of you may be familiar with child psychiatry access lines. They have them in all 50 states. It gives anyone a chance to dial a doc, to dial a child psychiatrist and ask a question. We have it here. Our school-based therapists can call, our primary care docs can call. Me as an adult psychiatrist, I could call the line if I want and get some answers. But it's really, how do we, again, help people with that expertise out in those rural communities? One of the things we're really thinking about, and this is kind of a new and emerging thing across the country right now, is who is the larger behavioral health workforce? We have thought, okay, licensed social workers, marriage and family therapists, psychologists, psychiatrists, nurse practitioners, and we kind of get stuck about right there. There is a larger behavioral health workforce that we need to be thinking about. And in Washington state, at least, they have actually said, you know what, we're going to take a bunch of people with bachelor's degree, we're going to give them some behavioral health training, and they're going to get certified in behavioral health that's not a master's degree, a PhD, an MD, a DO, a nurse practitioner. They're not going to have to do that. We're going to give them a little more training. And I had this experience out when I worked for the Indian Health Service. The IHS back in the 70s and 80s did this. They trained just local Native individuals to be the behavioral health outreach person contact for people in very, very rural communities. And now we're looking at barbershops and EMTs and fire departments and faith communities, and just really thinking who is this larger population that we can give them some basic skills. They can come in, even peer supports, they can come into our primary care clinics and help us with integration. They can come into our behavioral health clinics. There are issues around payment in Washington. Medicaid has decided they're going to pay. If you graduate from this BHHS program, they're actually going to provide Medicaid codes and reimbursement for this larger behavioral health workforce. In collaborative care, but you don't have to have a license. It can be someone with extra behavioral health training. We're trying that here out in Western North Carolina right now. So that's a real thing I think everyone needs to think about. And we get hung up on reimbursement, but if you've got an empty social worker position for a year, we used to call it vacancy savings. You got a bunch of money getting stacked up there because you don't have that position filled. What could that look like with folks, even on warm lines and those sorts of things? What is that larger behavioral health workforce? And then kind of the last thing is brainstorming about in your community, how do we get local community students, how do we get them interested in behavioral health, and how do we get them to come back after they've gone to school? What does that look like? What do we need to do to entice them back to their own community? Because a lot of folks will, wherever it is they go and train, they tend to settle down there. We know that happens. How do we get folks to actually come back? What does that look like? And the organization that I work for, our goal was to train people in the remote area. So we train them out here in rural Appalachia, and our goal is to get them to stay. And right now, we have a huge program here with psychiatry, family medicine, internal medicine. We have been incredibly lucky. 65% of our graduating residents stay in Western North Carolina. And that is pretty amazing given we're graduating 50, 60 students a year and they're staying. And it's just the mission has worked, and it's taken us 50 years, but it's really working that we're able to get people to stay. So how do you entice these students? I remember some high school students coming in who were interested in behavioral health back years ago. I know there's HIPAA and there's things we need to be thinking about, but there truly are ways to get folks interested. I have a personal story. My own daughter, who went off to university to be a marine biologist, of all things, she ended up with a wildlife management degree instead, because there's not an ocean everywhere. And she's just moved back home and she's working for the Forest Service. And I'm shocked. I never in a million years thought my daughter would move back to our community and be employed member of the workforce there. And she's with the Forest Service, and it's so cool to actually see that happen in my own life, because we're in a very rural community in Southwest Colorado. So just a lot of things to think about. And again, I'm just really curious what you've done. This is just a quick slide on the psychiatry access lines. They're all over the country. There's actually a national organization. You guys can see what you have in your area. Maybe you're already working with them. Project Echo, we have a big Project Echo across North Carolina. This is an autism program called Teach that's actively up and running right now, and it's specifically to help with autism. The frontier, of course, it's not so much the frontier anymore, is how do we use telehealth to help us do our work in behavioral health. We're going to see a lot more self-care using apps. So there's self-management going on. How do we text patients, get messages back in ways, patient portals we use, in ways that can keep us in touch with patients and maybe help if we don't have enough staff to take care of everybody. I'll be curious if any of you have tried, there's some self-management apps, things like Beat the Blues have been out there already, and kind of that's just going to expand. That's going to go pretty wild with what we're doing in the future. AI's out there, avatars to do therapy, all kinds of interesting things. We need to be careful, but we need to also think about how we can embrace how to take care of patients effectively and to actually increase our reach in rural areas. So I'm going to stop there. This is a picture of a drying barn and a tobacco field. This could have come right out of Bladen County where I was raised. And I'm just going to kind of wrap up with that. And Emily, I was thinking I would stop sharing my screen for conversation.
That sounds fine. Yeah,
Okay, there we
sure.
go. Here's our
Um,
crowd.
I've written down a lot of questions, and I would love to kick us off with one if that's okay, and ask a few, and then in a moment we can open up to the chat, or if there are folks that want to unmute, we're a pretty small group, so we can just really make this a conversation. But I wanted to just kick it off by asking if someone is transitioning, if a provider is transitioning from providing care in an urban area to a more rural area, what is the one thing that you would want that provider to know as they make that transition?
I think the biggest thing is how do I connect with other people in my profession? And what we did is we had 6 service units out in Western on the Navajo reservation, And those six psychiatrists, we would come to the middle of the reservation in Chinle. If anyone's ever been to Chinle, a beautiful place, we'd come in the middle and there's one restaurant. We would eat and talk and share and just have that time together. When I worked in Durango, we would call up all the psychiatrists out in Southwest Colorado and we would do the same thing. And I just think there's a lot of room. It doesn't necessarily mean who's in that clinic or who's in that town, but who is close 50 to 100 miles away? Who's close by? And for you to make the effort, I went up to another town and said, "Hey, I'm here. Let's go out to dinner." I that's just my personality, and that was the way that I found, and it worked. So I think that sense of I'm going to be lonely, I'm going to be professionally isolated is a lot of what keeps people from going out there. So think about ways you could do that. And then the second thing, if I had to do too, Emily, was think about, well, how am I going to do continuing education? And a lot of that is I'm going to go to my the American Psychological Association, the National Social Work Meeting, NAC, which is the National Community Health Center meeting. NAC has an organization in every single state. If you're with an FQHC, and they have their statewide meetings. The American Psychiatric Association, yeah, they had a huge national meeting in San Francisco, but I've got a little meeting for my NC Psychiatric Association at Myrtle Beach coming up in September. So just keep your radar out for what's available and how you can personally, don't wait for it to come to you, go looking for it, because it's out there. Even in this remote Navajo reservation, we were able to get together because we made an effort to do that. So just keep that in mind, because it just gets people so turned around and not wanting to do this. There's a lot out there, and I swear, I think I feel lonelier living in the town of Asheville than I ever felt living in rural Colorado. It's just interesting. You just meet a lot of people when things are pretty tight knit.
Yeah, so piggybacking off of that and keeping things tight knit, one of the things you talked about was that in these rural communities, in practice, there is a cohesive team environment. So you are encouraging folks to look for their colleagues, to go out to make those connections. But then in clinic and in the practice environment, having that close-knit team is something you mentioned as a strength in providing rural behavioral health care. How do you adopt and develop that small team, close-knit culture? How do you build that culture in rural settings? And what are maybe some things that folks who are in an urban or a suburban setting can adopt in their own practice to build that close-knit, cohesive team culture?
Yeah, one of the things is always you have to start at the top of the organization. You have to have leadership support. The CEO, the CFO, all the C's have to be in some sort of agreement that recruitment, retention, work, we have a whole new workforce. They're younger, and that work-life balance is super important to them. Actually, sometimes more important than money, more important than the salary is work-life balance. So at the top of the organization, there has to be support for, okay, so what we did is we had a weekly meeting where the psychiatric staff and the therapy staff, we all came together and we presented patients, and we talked amongst ourselves, and we helped and support each other, whether it was someone with schizophrenia or someone with severe depression or a personality disorder, and all of us being in the room. Not the psychiatry was on one hall, therapy was on one, case management was on one, child was on one. We had everybody in all these different hallways. But we came together and talked about patients and talked about how to provide care to patients. So that was a really cool thing that we did. And someone had to say, wow, that's an expensive hour. All these folks not doing therapy, all these psychiatrists not seeing patients. Oh my goodness. They had to say, I'm okay with eating this cost because it's going to help me keep this team. It's going to help develop this team. So that was kind of a clinical thing we did that I thought was really cool. And I really enjoyed that. I really enjoyed, talking about folks across team structure. In one of my clinics, we actually mixed up the exam room. So you may have a therapist exam room and a PCP's next to it. We tried to mix it up to kind of almost force the elbow rubbing. That didn't work so necessarily so hot because sometimes you needed a sink in a room that had a couch. And so, we tried something and it wasn't all that successful, but our thoughts were in the right direction. And then this is the social stuff. So having lunches and potlucks and celebrating birthdays in a small clinic. Almost everybody knows everyone's stuff. They know when they're having a baby, they know when they're getting married, they know when their birthday is, they probably know when their anniversary of working in the clinic is. All the emails go out. They know whose coffee cup was left in the kitchen that's dirty. There's all kinds of stuff people know. But so there's the social side, and then there was the clinical side that got us in the room and said, hey, the psychiatrist doesn't know everything. It's not like food chain here. We all have a piece of the elephant here around patient care. Let's have a place. And there was a real focus on psychological safety. And if folks don't know what that is, I think it was Google that kind of came up with it. But everyone needs to feel safe in a group to speak up. Otherwise, they won't speak up. They feel belittled, criticized. They need to feel safe to speak up. So there has to be some focus from administration on this concept of psychological safety. And I really encourage you guys to look that up. It's really cool. I have several slides I show on it to say you're not going to have good team-based care if you don't have this. You need to be curious instead of critical. There's things you need to do so that everyone in that room feels safe to speak up and say, well, you know what? I saw Chris 2 weeks ago and he looked great in the coffee shop with a friend. That is a great thing to let us know when everyone's like, oh, Chris is really doing poorly and blah, blah. If that person didn't feel safe to speak up, there's a piece of information that would be missing. So those would be some thoughts around that, Emily.
And you just mentioned rubbing elbows with the PCPs. And you had also mentioned in your presentation that integrated care and utilizing those connections with primary care and with FQHCs, that's one of the best ways to bypass these barriers to care in rural areas. Could you expand a little bit on the starting points or some of the facilitators for integrated care?
We got really lucky. It was 2006, and Dr. Druss, who's on our call, was one of the mover and shakers back then. An important paper came out about the shortened lifespan of people with serious mental illness, and I don't remember Dr. Druss where it was. I swear I think it was Las Vegas, but I'm probably not thinking about that straight. But we all went to a conference, and in one room was Dr. Druss and his colleagues talking about the mortality gap. And in the other room was Dr. Jürgen Unitzer from the University of Washington talking about how do you get behavioral health treatment in primary care settings. And in Dr. Druss's side of the room, it's how do you get primary care in behavioral health settings. So they were talking, and I'm sitting there going, oh my gosh, I think I'm at a new frontier here. I didn't know about this mortality gap. I thought it was 15 years. Well, it went up to 2025 in the course of new medicines and things kind of happening across the country. And I just felt like, oh my gosh, which one do I want to tackle? This is a whole new idea to me. I had been with primary care in the Indian Health Service, but we never went in the same clinic and did a whole lot of talking and consulting. So it has been, started with me in 1993 with the Indian Health Service, but then in 2006 got kicked off for me. Several of my leaders were in that room, and we all came back and said, what are we going to do? We started partnering with PEDS practices. We started talking about how do we bring primary care into our mental health center. Funding started to come out, federal funding around integration. Some of you may be CCBHCs now. FQHCs and mental health centers started to merge. Medicaid, Medicare came out with codes specifically to provide collaborative care to patients. And I just had the most fun with Dr. Druss and others at the American Psychiatric Association, we would all do presentations. We started an integrated care committee. Um, it was a fun time because it was new. The research was coming out. We were trying different things. I just love working in primary care. Just before this call, I was working with the whole primary care case list on sending the notes to them through the medical record about, hey, I suggest this, I suggest that. But that's how we got started. And now it's so much easier to get started. There are organizations like this one, the Ames Center and others just across the country that are just sitting there waiting to help you do it. And that wasn't available. We did it ourselves. It was a lot of fun, and now it's even more fun because a lot of or easier, I should say, a lot of the resources are sitting out there for you now that weren't there when Dr. Druss and I got started in our integrated care journey. So I think if you don't have enough staff at your site, you don't have enough behavioral health staff, well, take a one or two of them and go over to primary care and stop the referrals to you by providing it over there. Because that can really make a difference in your wait list and sort of what's going on. There's so much stigma with mental health. We still have not cracked that. That if you go to primary care and do it instead, no one knows why you're in the waiting room at primary care. They think you're there for a diabetes check, and you could be there for mental health and no one knows. So in small communities, the stigma around mental illness, I would say, is much higher than in a metropolitan urban area. And that is one of the ways to overcome that stigma. And for those of you who work out there and we work here, we have a high no-show rate, especially for first visit. And I think a lot of that is around stigma. So it does help address that too, Emily.
Yeah, thank you so much. I want to ask you one more kind of more personal question before we open it up to some folks in the chat and anybody else who wants to unmute. I don't want to dominate all the question asking, but I did want to ask you, as you're coming to the end of your career and you consider all of the challenges that you faced in providing rural mental health care and primary care and navigating those challenges, would you do it all over again?
Oh, yes, without a doubt. I have had the the honor of having the most incredible career. I find it amazing and so rewarding to work in communities. I feel like I'm making a difference. You're a small mental health center. There's a lot of folks that rely on you. There are organizations that turn to you when something happens. Some random murder or tornado or whatever it is, they turn to you because you're about the only person in town, and they really do rely on you. And I have just really found it to be eye-opening and just personally very gratifying. There are days when I don't have enough psychiatrists and I'm frustrated. But for the most part, if I sit back, I go, oh my gosh, this has just been fun. It's been very rewarding. And I am proud of being able to go out into these areas and be able to provide care.
Thanks. Thank you so much. That's what, after years having the wonderful opportunity to work with you, that's what I figured your answer would be. But thank you so much for
Sure.
revealing that. We do have a question in the chat from Lynn, who asks, do you have any recommendations for serving older adults with mental health and with substance use disorder? So I'm thinking more along the lines of that dual diagnosis situation in rural mental health care arenas.
Well, I will say there is no better place. This is a population that won't necessarily come to your behavioral health. I mean, the older they are, the more stigma there is around mental illness because in their generation, no way would you ever talk about this. So I mean, that puts this older population in an interesting position. What I have seen is a lot of going to primary care, getting involved with the geriatric population. And folks don't remember, but one of the very first studies of integrated care, the collaborative care model, was done in 1997 And it was with the geriatric population because the Robert Wood Johnson Foundation was worried, just like Lynn is, about we can't get behavioral health care. We can't get senior citizens to go to mental health. We can't get them to go. They're not being recognized. And so they set up mental health treatment in the primary care setting. So the impact model, which is what so much more of this was based on, was started in a geriatric population for just that reason. And there are now a number of studies of integration with dementia, depression, anxiety, these sorts of things. And then, Lynn, we also, the North Carolina Agency on Aging, Council on Aging, kind of like you, we have these wonderful resources where my residents go to all the time. They type it in and they find all these different things in different communities to refer patients to. The combined substance use piece of that makes it super hard. But I have just found with this population, you have to meet them where they are, and that is in primary care. And so, how do you do that, and how do you make it? Medicare came out with the first reimbursement for the collaborative care model codes. They came out with it for Medicare patients. So there's certainly a recognition around this. And Lynn, if you have anything else to add to that, please let us know. But that's been one of my thoughts. It's really hard to have a geriatric psychiatrist or someone. We have people with big heart for geriatric patients who may want to do that therapy in your clinic. But that's really hard to find sometimes. And
I
Lynn, I don't
like
know what you've done in Pennsylvania around that.
Thanks, Dr. Raney. I'd love to open it up to anybody else that has other questions, whether, like I said, we're a pretty small group. If you want to unmute and just ask your question directly, or if you feel more comfortable typing it into the chat, I'll read it out to Dr. Raney. In the meantime, as we kind of get towards the end of our hour, I'm going to ask Stephanie to go ahead and drop the post-event stamps are required survey link in the chat as well, just so that everybody has a little bit of time. To fill that out. So if there are any other questions, please, I know I have a few, but if there are any other questions, please feel free to unmute or type those questions in the chat for Dr. Raney.
And I noticed, Robert, you said something about, sad to say it, but jail staff are the largest mental health workforce. And that is true in a lot of communities. They have all kinds of great funding. And sometimes, with funding, I mean, you can do it all telehealth, teletherapy, all sorts of things in a corrections setting. So you do kind of see that. Wherever the funding is, you will often see the staff they're able to have more higher salary. The issue we have here is the FQHCs are scooping up all the patients, or I mean all the staff, because they can pay a little more than some of the other behavioral health organizations. So social workers, you're going to have so many, and you're going to rob Peter to pay Paul. They leave community mental health and go over to primary care. They leave primary care and go to private practice. Here, you're just kind of moving people around on the Titanic sometimes. So what does it really look like when you can recruit people?
I see that Stephanie has kindly shared the post-event evaluation survey in the chat, so please everybody just take a second to click on that and fill that out while we're chatting. I see we have a question in the chat, Dr. Raney, from Madeline, who says, what kinds of needs do you see for research and evaluation in the rural mental health care space in the coming years?
Well, I think it goes back to what I was saying before about who were the larger behavioral health workforce? How can we really, and there's a lot of literature about EMTs and fire departments. Some of them are just news. Some station went out and interviewed the fire department and the incredible work they're doing, driving those trucks around to check in on elderly folks. But we do need to answer the question is this effective? Is this program to teach barbers about how to talk to young Black males in urban areas? Does it reduce PHQ-9 scores? Is it effective? So I think that is going to be a huge need down the road, because that's like sitting on the cusp of, you see what's coming. And in my mind, as reimbursement follows some of these things, we have to answer the question is it effective? And we've done this in some situations with in integrated care, looking at, okay, well, if I hire a bachelor's in psychology to do my collaborative care and build the codes, is that going to be as effective? Do 50% of my patients have a 50% drop in their PHQ-9 scores, just like they would with the social worker? I think we're going to need to answer that question. So, right off the top of my head, that is something that I think we need to be thinking about and trying some things. What level of training would it take for it to be effective? What doesn't work? What works? I think also there's a lot of work around measurement-based care now coming out to a lot of different communities, and the implementation science around what works and what doesn't in attempts to go into behavioral health now and do what they've been doing in the rest of medicine forever, which is, monitoring your blood sugar. Well, how about we monitor your level of depression? So I think there's going to be a lot of work that comes in, especially around the implementation science of that. We know measurement-based care works if you do it. Well, why don't people do it? So it's that kind of a question. And then there's always a push in the field around psychiatry for long-acting injectable antipsychotics and clozapine, and why isn't that being used? And what can we do about it? So there's been a lot of interest within the APA about that in the last couple of years. Just some thoughts, top of my head, Emily.
Thanks. Robert, in the chat, you said that you had a question, so feel free to either put it in the chat or go ahead and unmute. We still have 2 minutes left until the top of the hour.
Well, I re-entered the behavioral health direct practice right as the pandemic started. And I ran into the kind of thing where the people wanted to come and see a therapist in person. So my practice built quickly because I was willing to do so. But at the same time, everybody struggles with transportation problems no matter where you are. And so I think a lot of the people need to be more aware of what the value added services of their insurance is, because sometimes you can get transportation from that. But how do you fill those kind of gaps? And I remember years ago working with a homeless shelter where we had an RV and we went out in the community and stayed at different places at different times. And so maybe meeting the patients where they are might be more effective.
Yeah, absolutely. And we had a situation where we had a telehealth company that called me and they wanted to set up telehealth in the libraries in the community, because the libraries can help be that reach patients where they are, and to be there and be supportive and maybe do a training or have a community meeting. But yeah, we had a lot of and out in rural communities, do people have the data to do it on their phones, right? That data's a big issue. Do they have the internet connectivity? But we also did a van. The vans would go out to the Indian Health Service. We'd do mammograms. We did all kinds of stuff. They're behavioral health vans. I always liken it to the good old days of the mobile library coming around and literally parking in front of my house. They met me where I was as a small kid in a small rural town to get my books in the summer. But I like your idea. Meet them where they are. How do you do that? How do you pay for the van? What's that community fundraiser or getting a grant? But I think that's important. And I also think educating people around the advantages of telehealth and having that support may actually help people move their ideas about it. Most of them have to come into a clinic, get the connectivity, and your provider may be somewhere else, but they at least get to a library or somewhere where they have that, or a van or somewhere where they have that connectivity. That's important. That's a really good point.
All right, everybody, that is all of our time for today, unfortunately. Thank you so much, Dr. Raney, for a lovely presentation and for having this conversation with us today. Everyone, please take a moment to fill out the SAMHSA required post-event evaluation survey. And that is going to be it for today. Thank you so much, everyone. Thank you again, Dr. Raney. And I hope everybody else has a wonderful rest of your day.